Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosing.
and we are Oncology Brothers. Today, we're honored to be joined by Dr. Jeff Sharman, not only because of his success as a clinician and as a researcher in community settings, but also because of the topic in hand, CLL, chronic lymphocytic leukemia. The course of this disease has changed since we have started using BTK inhibitors, and Dr. Sharman was the first to ever give this medication here in the US. We're going to focus on the current standard of care and how to manage this disease in our day-to-day clinic. Dr. Sharman, welcome.
Thanks so much for having me, guys. I'm looking forward to this.
Oh, Sherman, thank you for joining us. Since your first patient who received ibrutinib, this disease is, of course, taken turn for good, and few more changes have been implemented. Before diving into different BTKIs and other treatment options that we have available for our patient population, I think it is important to set the stage. That is, what is CLL and when it's diagnosed? CLL is chronic lymphocytic leukemia, which is usually diagnosed in elderly patient population, about 70 years being the median age. But not everyone necessarily needs treatment. Just to start off, say you have a patient who presents with mild leukocytosis, otherwise asymptomatic, and now diagnosed with CLL. How do you stage these patients in terms of the lab work and images that you all order? And importantly, do you get bone marrow biopsy in these patients at all?
Great. Yeah, it's a good place to start. So, CLL stands out like a sore thumb when you get a CBC and somebody's white count's 25,000, and invariably these patients are referred from the ER because they were there for something completely unrelated, or maybe a primary care doc who's been following them for other unrelated conditions gets a CBC and something stands out. And so really the diagnosis is made by flow cytometry, peripheral blood flow cytometry, and that's good enough for the diagnosis in most cases. I will tell you that there are a number of times where there are things that can mimic CLL, and it's important to sort of be cognizant of these because they have different clinical courses. So indolent mantle cell lymphoma can oftentimes be confused. It can have a circulatory component, oftentimes presents with splenomegaly. And so that's one that can be distinguished by FISH. In addition, circulating marginal zone lymphoma can sometimes look a lot like CLL. And even circulating follicular lymphoma can sometimes be confused for CLL. Oftentimes on flow, those are going to be clear enough, but there are times where I've called the pathologist and said, hey, tell me about this CD5 or tell me about this CD23. How's it looking? FISH testing is another component to this. FISH testing for CLL prognostic purposes doesn't necessarily have to be done at diagnosis, but I like to do it before I start treating patients. And sometimes I'm getting FISH because I want to distinguish between mantle cell lymphoma and CLL. So I often do get FISH at diagnosis, and it serves as a useful point of discussion for the patient to say what the future might look like. And then finally, I like to get the IGHV mutational status, whether they're mutated or unmutated, because that tells me a lot about sort of what I can anticipate out of the future kinetics of the disease. The unmutated tends to be more rapidly growing. The mutated tends to be a little bit more indolent. And with those three tests, I feel pretty comfortable that and physical exam being enough. I don't necessarily get a CT scan unless I have reason to. Why might I do that? If somebody tells me that they've had any abdominal bloating or abdominal discomfort, or maybe their pant size have changed, or if they've got bulky nodes on clinical exam, I'll do a CT scan because people can hide a lot in their belly. That I've sometimes been impressed by how much is there, even in the setting of pretty minimal blood counts being abnormal. So I don't necessarily get a CT scan. What I don't do, out of the questions you asked, I rarely get a bone marrow biopsy because it doesn't really add a whole lot.
I think just to recap on a few things, even though we're getting FISH here, we're looking for some bad prognostic markers, particularly TP53, deletion 17p, and even with IGHV unmutated is a little more common than IGHV mutated. So I think all that information helps, but from patient's perspective or primary care physician perspective, not every single patient needs to be treated. We're getting this information to get started saying what next.
Right. So my first question isn't so much about their mutated status or not. It's whether or not this patient is optimal for fixed duration therapy or an indefinite strategy. So there are two main treatment paradigms in the frontline setting. One's BTK, and one is obinutuzumab venetoclax. And interestingly, if you look nationwide, the obinutuzumab venetoclax, I think, is significantly underutilized relative to the quality of the data. So it's got about a 15% market share for frontline CLL currently in the US. And honestly, I like that regimen a lot. I think that obinutuzumab venetoclax is a great regimen. It's just that it's logistically challenging, and it's not super easy. It takes a little bit more work, especially in the patients who are IGHV mutated. Look, we know from CLL14, which is one of the big data sets, that about 8 out of 10 patients, or 4 out of 5 patients, they're going to be free from any therapy for about 5 years after starting this regimen. And so you get 12 months of therapy and then a long treatment holiday. I think patients really like that. So in my mind, I'm sort of always thinking, is this a obinutuzumab venetoclax patient, right? And what does that mean? Well, is this a patient who's got good access to transportation? Because I like to do this in the outpatient setting. Can they get back and forth to clinic? Do they have decent renal function that I don't have to be too terribly concerned about them? What do their nodes look like? I don't know how many times you've gotten CT scans that say, hey, the patient has, retroperitoneal nodes measuring 3 centimeters. And then you actually go look at the images and you realize there's but in aggregate, this patient has 14 centimeter nodes and big bulky disease that you don't always get on the read. So really important to look at those images yourself, because again, that optimal patient doesn't have that huge bulky disease. And if they're motivated, they want a fixed duration, I think it's a great regimen. And what we know from various studies is that you'll cure the lymphocytosis with a single dose of obinutuzumab. So you kind of have to risk stratify these patients. How high is the risk for tumor lysis? And that's a combination of their lymph node size and their lymphocyte count. And so if their white count's above 25,000 and they have lymph nodes greater than 5 centimeters, that makes them high risk. If they have lymph nodes greater than 10 centimeters, they're high risk. If their lymph nodes are, if their white blood cell count is if it's an or, they have white blood cell count greater than 25,000, or their lymph nodes are greater than 5 centimeters, then they're intermediate risk. But the reality is their lymphocytosis is gone after a dose. And so then you're really just dealing with the lymph nodes. We've done studies where we've looked at it. We don't really shrink the lymph nodes a whole lot in the course of a month or two of obinutuzumab. So kind of the lymph nodes they're going to have when you start the venetoclax. But a lot of those patients will be rendered low or intermediate risk, where I feel very comfortable doing it all in the outpatient setting. And then it just becomes an issue of logistics. And what I tell my patients, I'm like, look, it's going to be a pain in the butt for a month. You're going to be in here a bunch of times. We're going to see each other a lot of times. I'm going to have you take things at certain times. But once we're done with that month, the good news is the drug's very well tolerated, and most patients don't really complain about being on venetoclax. And then after 12 months, you're off, and chances are you won't need another therapy for several years. So
we started off that not everyone needs a CAT scan, but again, that is for the patients that are asymptomatic and you're not planning to treat. But when you're making that treatment decision, that CAT scan is important, because when you're starting venetoclax, risk stratifying is so important on how far closely you're going to monitor, because that step-up dosing and how you're going to monitor for TLS is based on that low, intermediate, and high risk. So I just wanted to bring that.
Yeah.
So one thing that I want to dive into when we're talking about this combination obinutuzumab and venetoclax, often what I've done is started off with obinutuzumab, exactly to what you were saying, see how these patients doing, and then start with venetoclax thereafter. Any reason for us to start them together, or do you ever switch to sequence?
No, in the CLL14 study, which is what led to the approval, they got they effectively got most of that first month of obinutuzumab before they ever started the venetoclax. What's a little bit clunky is when venetoclax was developed, originally it was in the Murano study in relapse disease where the venetoclax started and then the Rituxan, and I admit I don't do it that way, but so there's some confusion in terms of how the studies were done, but at least in the frontline setting, you do the obinutuzumab first, you get rid of the lymphocytosis, and then 3 to 4 weeks later, you start the venetoclax.
And thank you so much for stressing the importance that in community, we don't tend to utilize this combination often. And I must say that we rather shy away because of the supportive measures that it actually requires.
So a couple things to know. Obinutuzumab as a single agent has a rate of tumor lysis of about 7%. So even just starting obinutuzumab, you need to be thinking about tumor lysis. And I've been burned enough times to know that I actually do start patients on allopurinol, particularly if they have a really high white blood cell count. But you get them through that. And then venetoclax has a very specific step-up dosing where you start at 20 milligrams per week, then you go to 50 milligrams per week, 100 milligrams per week, 200 milligrams per week, and then you start them on 400 milligrams. And early in the development of the drug, there was a singular patient who started at 50 milligrams and went into tumor lysis and died from it. So, it's important to know that venetoclax needs to be monitored carefully. And so what I do for my patients is I have them get a set of baseline labs. I look at them, make sure everything looks good. Their potassium's fine, their creatinine's fine, no surprises. And then what I do is I have them take their first dose of venetoclax. I have them take it around like 5 to 6 in the morning that first day. And that way what I can do is I can have them come into clinic, in the late morning. I might even give them a liter of fluids if I'm concerned about it. But I can check labs between 12 to 1 with stat labs to include uric acid, phosphorus, potassium. And I check those labs to make sure it's okay. Then what I tell them is the next morning, I'm going to have them come in early in the morning, 8 a.m. or so, check a set of labs, but don't take venetoclax until we give them the permission to do so. And so they bring their venetoclax with them, and then as soon as we see the labs, we give them the thumbs up, and they take their venetoclax. They're good for a week at that point. I do the same thing with the 50 milligram dose. And at that point, most of the risk of tumor lysis is significantly gone. Occasionally, if somebody's really got bulky adenopathy or maybe mild renal insufficiency, I'll do that again at the 100 milligram dose. But for the most part, at 100 milligrams, you can start cutting back the lab monitoring.
Before I move on from Obin-Ven story here,
Yeah.
the other thing I want to bring up is patients with high tumor load. At times you can see infusion reactions with obinutuzumab, so that's another thing that we have to be a little more mindful about.
Yeah, if I could just say something about that, because obinutuzumab in CLL is a superior antibody to rituximab. But the issue, I always say, like, rituximab's like thunder and obinutuzumab's like lightning. And with rituximab, you kind of get these rolling infusion reactions. You turn up the dose, you turn down the dose, you turn it back up, it comes back, you turn it down, and it can be a tricky drug. With obinutuzumab, generally when the person gets somewhere between, say, 15 to 30 milligrams, they start looking at you funny, they scratch their nose, they kind of have a slightly different look, and then wham, if you keep going, they're going to be hypotensive on the floor before too long. And what you have to do is your infusion nurses just need to know, like, in that first 20 to 30 minutes, an infusion reaction is likely, and the quicker you stop it, the less bad it is. And then the crazy thing is that infusion reaction doesn't come back. You give them 30 minutes to cool off, and they very rarely react again. So that's why I call it more like lightning.
Interesting take on that. Something to consider when these patients cannot be given this particular combination. Now, turning our side to BTK inhibitors.
Yeah.
If you have to utilize one of the 3 that are approved, ibrutinib, acalabrutinib, and zanubrutinib, any one particular one that you would lean on or particularly consider?
Right. Well, this gets fascinating, right? Ibrutinib was the first one, and it was market dominant for a long period of time. There have now been head-to-head studies, primarily in the relapse setting, where acalabrutinib was compared to ibrutinib, or in a different study, zanubrutinib was compared to ibrutinib. And in both studies, there were significant advantages for the second-generation BTK inhibitors. So I have to say, I don't use ibrutinib all that often. One of the data sets that's out there that I've been attached to and think about a lot is the what we call the Elevate TN study, and this is an area where I think there's been a detail that's emerged that's kind of interesting, which is that was a 3-arm study compared to chemoimmunotherapy versus acalabrutinib or acalabrutinib in combination with obinutuzumab, and with subsequent updates, we're seeing a pretty significant benefit with the addition of obinutuzumab. So if I'm going to go with a BTK inhibitor, I'm also asking myself the question, is this a patient who would benefit from obinutuzumab? What do I mean by somebody who would benefit from obinutuzumab? I'm thinking to myself, is this a patient who's, able to get into the clinic, able to get infusions, doesn't mind the infusions? It comes with a little additional toxicity, more cytopenias, maybe more pneumonias and so forth. But at the 4 to 5 year mark, you're looking at a 10 to 12% improvement in progression-free survival with the addition of obinutuzumab. So it's not trivial. And there's even, it's not statistically significant, but there's a trend towards a survival advantage. So if I'm going to do a BTK inhibitor, I'm thinking that question in my mind. Between acalabrutinib and zanubrutinib, I think they're both very good drugs. Maybe a little bit more hypertension with zanubrutinib, but very good drugs. And I think, look, just get familiar with one or two of these drugs, and you're probably fine. I don't think you can pick wrong there.
And then just briefly, when we're talking about some of the side effects, for the most part, they are well tolerated. One big thing was acalabrutinib and zanubrutinib perhaps have a little less cardiac toxicity, AFib. One odd side effect that we run into with acalabrutinib ends up being headaches, which is very responsive to caffeine. So just a few nuances. I think that in the community, we just have to get comfortable saying, this is what I'm going to stick to and know that supportive care.
Now, talking about particularly for IGHV mutated patient population, FCR.
Yeah.
When do you consider this in upfront setting at this point in time now?
Well, if it tells you anything, I haven't used it in a couple years, and I know from quite a few of my colleagues, they also don't use it all that much. Here's the thing: FCR in very select patients may be a curative option, but those are young patients, IGHV mutated, favorable FISH, and by favorable FISH, I'm talking about 13q deletion or maybe trisomy 12, maybe the normal cytogenetics, but not the 11qs, not the 17ps. And when I say young, I'm thinking like less than age 60. But here's the thing: the CLL13 study has just been presented, which actually compared obinutuzumab venetoclax, rituximab venetoclax, triplet therapy with ibrutinib, venetoclax, obinutuzumab. Did I get that right? I think so.
Yes.
And then chemoimmunotherapy. Now, it was investigator's choice of BR or FCR, but obinutuzumab venetoclax beat chemoimmunotherapy in that study as well. And so I actually think that OB-Ven may very well prove to be better than FCR, and you certainly get rid of a lot of the downstream secondary malignancy risk with regards to the myelodysplasia and so forth, which isn't a huge number, but can occur. So, I haven't used FCR hardly at all, and I think that FCR was popularized after MD Anderson did it, but the median age in that study was 57 years old. And as you point out, this tends to be a disease of the elderly. And I think that when FCR got exported to community medicine, it was a real train wreck because, FCR was given to 80-year-olds. And I inherited a patient one time who needed 50 units of blood transfused after FCR, just from the prolonged cytopenias. It's not a trivial regimen.
Yeah, no, I think we're glad that we have different options than
Yeah.
FCR, just because purely from management perspective side of things.
Yeah.
You briefly touched upon this. In terms of combination, is there any patient that you would consider using venetoclax and BTK inhibitor combination?
Yeah, so fascinating thing to sort of tear that apart. So the GLOW study compared ibrutinib venetoclax to chlorambucil obinutuzumab, and it was sort of one of the last studies that still use obinutuzumab chlorambucil. Problem with that study, the median age was 74, and ibrutinib in older patients gets to be harder. And in fact, if you look at the rates of grade 3 and 4 diarrhea with the combination of ibrutinib venetoclax, it almost had rates similar to idelalisib, which is nobody's favorite regimen. Now, on the other hand, if you look at the Captivate study, which was sort of a U.S. academic population where the median age was much lower, ibrutinib venetoclax looks fabulous. So it's a very age-dependent regimen. Based upon the GLOW study, ibrutinib venetoclax was actually approved in Europe and Canada and several other places. It was not approved in the U.S., and I don't think it will be. That having been said, there will be studies forthcoming of acalabrutinib venetoclax, which I think will get rid of a lot of the toxicity concerns, and in a younger population. So in a younger population motivated by oral therapy, if I had to guess, and this is purely speculation, I kind of suspect that BTK Ven may prove to be better for the IGHV unmutated, and the OB Ven may be the right ones for the IGHV mutated. That's speculative. I do not have data for that, but it's just kind of taking little bits and pieces from 10 different studies. In the meantime, would I use it? I'm using it a lot on study, but to me, it's still a study question.
Glad we have multiple treatment options for our patients beyond the chemotherapy that we are used to or we were used to. Dr. Sharman, you've covered a lot of information here in a very short time. We cannot thank you enough for going over the current standard of care for CLL. Just to recap, our talk with Dr. Sharman, which we did cover quite a bit from standard of care treatment options for CLL patient population. One of the key takeaways is that not everyone needs treatment.
Agreed. But once you've made the decision that this patient's going to need treatment, knowing their mutational status, including IGHV or TP53/17p deletion, is very important. Another important discussion with the patient is going to be, do you need or would you prefer time-limited treatment versus lifelong BTK inhibitors?
Then we also covered some of the nuances around venetoclax and importance of close monitoring these patients with lab work to monitor for tumor lysis syndrome. Thank you for tuning in to this episode. For more updates and discussions around standard of care treatment options and practice-changing data, follow us along the Oncology Brothers.